Myles, Textbook for Midwives, Chapter 4, Notes. Chapter 4, International Midwifery, Della Sherat. DELLA space SHERRATT. Skipping over to page 50, as the more industrial countries find that they can no longer continue with the high cost of technology and medicalization of childbirth, they are likely to look towards developing countries for solutions, and this in turn will offer more opportunities in the future. Whatever the reason for the increase, it is likely that midwives will be working with vastly different cultures, traditions, and resources. Not surprisingly, some midwives may find themselves ill at ease and initially overwhelmed by their experience despite having developed expertise in their own country. It is fair to say that more attention is being given to the adequate preparation of midwives who wish to work in an international field. The practicalities of working in another country, obtaining permission and ensuring that the correct visa is obtained can be difficult. Many countries require a different visa if the intention is to work rather than visit. If the intention is to work, it may be necessary to provide evidence of the work to be undertaken, often by producing an official letter of invitation from the employing agency or company. Most embassies or consulates will provide the necessary information and documentation to apply for the correct visa. It is essential to have adequate medical insurance cover, particularly cover which includes repatriation, as the most common reason for an unscheduled return home is personal ill health. Also, there is an increase in the number of university programs that include elective periods where a short time can be spent in another country undertaking a small project or work experience. One factor which can influence adaptation to working in another country is careful consideration of the motives for undertaking this type of work. More research and study is still required on how and why midwives choose to work in another country in order to help identify factors which assist with their adequate preparation. On the whole, as with all career choices, there are varied and complex reasons why someone would choose this particular path. Some find themselves in a certain place at a certain time, able and willing to respond to opportunities as they are presented. Others have a burning desire to travel and experience the wider world. That is to say, they have moral, humanitarian, personal, or family reasons, or gospel, which would be include moral and humanitarian, personal, and family reasons, for choosing this particular professional path. Whatever the reasons, it is the responsibility of each midwife to explore carefully the personal motives for choosing this type of work. There is no one valid reason, only an issue of individual choice. Most midwives who have done such work feel that it allows them to develop greater flexibility, innovations, and self-confidence. Of course, much will depend upon the type of work undertaken, but the advantages and the friendships that develop whilst undertaking such work often outweigh the difficulties. Working in a different culture, Central to all quality care and practice is the need to be culturally appropriate and culturally sensitive. Providing culturally sensitive care, All of these require careful and sensitive exploration with each woman and family. Development of appropriate culturally sensitive care, The first essential, The first essential to the development of a culturally sensitive care is to listen to women. As often cultural traditions and beliefs are vocalized in particular practices or taboos, Assisting the male leaders in the community to consider practices and beliefs and the effects that these may have on childbearing women is possible, and where this approach has been used, it has had positive results. Going back, the first essential to the development of culturally sensitive care is to listen to women. As often cultural traditions and beliefs are vocalized in particular practices or taboos, sometimes the reasons For these beliefs or practices are lost in time and history and are too readily dismissed, especially by scientifically minded practitioners with their own professional cultural beliefs. In some countries, particularly in Asia, the cultural beliefs and taboos surrounding pregnancy and birth can make this particularly difficult. Frequently, myths and beliefs are not spoken about directly for fear of evoking bad spirits or bringing bad luck. Just to acknowledge the pregnancy, for example, might be viewed as dangerous. This in turn raises obstacles to the receipt of any midwifery care. For example, how can the midwife encourage antenatal care, promote health in pregnancy, or even advise on planned pregnancies in cultures where to do so is unacceptable unless care is delivered under another guise? In circumstances outlined above, the only way forward is to work with the local community, especially women's groups and community leaders. Where such leaders are usually men, this can raise other gender-laden issues. For the midwife, there may be tensions in how to work with or through male leaders in a way that will empower women. Some gender training or gender sensitivity courses may help, and it is essential first to identify together with the women any existing strategies. Assisting the male leaders in the community to consider practices and beliefs and the effects that these may have on childbearing women is possible, and where this approach has been used, it has had positive results. The important point to remember is that notions of empowerment are also culturally bound. Women from different cultures have different ideas about what they see as empowerment. Chitnis, 1988, Collins, 1994, Dawitt and Busia, 1995. Given the opportunity, women from all cultures have clear ideas about what they think would assist them to give birth in a way that is safe and yet culturally sensitive and therefore acceptable to them. The ICM Code of Ethics states that midwives work with women supporting their rights to participate actively in decisions about their care and empowering women to speak for themselves on issues affecting the health of women and their families in their culture or society. ICM 1993. Maybe I'm misunderstanding, but that just seems so patronizing to women. Midwives work with women supporting their rights to participate actively in decisions about their care. I can't help but think of the Carla Hartley quote again: the decision to birth at home is the decision to make all the decisions. But if anything, the midwives would be participating, and maybe not too actively, in decisions about women's care. Those decisions belong to the women. Use of appropriate technology, page 53. For example, it is at present not considered essential to give iron supplementation routinely to pregnant women and well-nourished populations. However, hemorrhage before, during, and after birth remains the major cause of death in countries with poor nutrition, social deprivation, and poor health facilities. Royston and Armstrong, 1989. In these situations, iron supplementation becomes essential. Faced with high maternal mortality and high levels of undernutrition, it is clearly appropriate to have a protocol that promotes routine iron supplementation to all pregnant women as one of a series of measures to combat high levels of anemia due to malnutrition. In more recent years, there is concern about training doctors to undertake surgical procedures, such as cesarean sections, without simultaneously providing good anesthetics and analgesia, hygiene, and sanitation for hospitals that offer these facilities. Is that saying there's concern about training doctors to undertake surgical procedures such as cesarean sections without simultaneously providing good anesthetics and analgesia? Is that saying that there are cesarean sections taking place without pain management? This is not to say such training should not take place. Clearly, the facts show that too many women still die because of lack of appropriate emergency obstetric care, lack of equipment, or lack of appropriately skilled staff to use the equipment. WHO 1991a. However, importing systems and tools that do not get appropriately adapted can adversely affect the quality of care. That makes sense. Whilst in themselves the tools may be good, if they are not adapted to meet the cultural complexity of the importing country, they may be ineffective or used in an inappropriate way. Whilst in themselves the tools may be good, if they are not adapted to meet the cultural complexity of the importing country, they may be ineffective or used in an inappropriate way. For example, there is almost universal acceptance that the partograph is a useful and effective tool, yet it is not without its difficulties. For midwives working in a country or a culture where the counting of time is not in units of minutes or hours, the idea of charting events on a graph can be very difficult. ... Unless local midwives and doctors have culturally appropriate tools to help them understand and interpret the use of the partograph correctly, there may be unnecessary and often unsafe cesarean sections being performed. In this case, the tool will not assist women, but in some cases may cause women to face a greater risk than they would have without the technology. Midwives working in an international arena, therefore, need to ensure that the technology they take with them to other countries is appropriate and that correct training is provided for its implementation and use. Beware the expert. Finally, it is also important to acknowledge that midwives have their own professional culture that can interfere with the provision of culturally sensitive care owing to the particular position they hold as professionals or experts. This is problematic for midwives. In an analysis by DeVries, 1996, comparing the status of midwives in different countries, the recurrent theme was the attempts to legitimize midwifery through the desire to make the practice of midwifery professional, or claims that it is. DeVries argues that this could be disastrous, not only for women, but for the survival of the art and science of midwifery. Salvage, 1985, makes a similar point when warning all nurses and midwives about the problems of being too professionalized. Salvage alleges that as nurses and midwives become professionalized, they are more likely to identify with the doctors than with ancillary staff, patients, women, and relatives. For midwives, this means forgetting that they should be with women. For this reason, midwives would do well to consider carefully DeVries' warning that, in order to survive, midwives must ask, survive for whom? For the good of the profession? For their own good as practitioners? Or for the health of the women and babies they serve? DeVries, 1996, page 172. I thought that was excellent. The role of the consultant midwife. Some really deep thinking should go into just that really one paragraph. That's on page 53 of Myles. The role of the consultant midwife, and the heading was Beware the Expert. The role of the consultant midwife, ... The temptations to allow oneself to be seen as an expert in these situations is even greater. Going back to the beginning. Whilst the above, the role of the consultant midwife. Whilst the above is an issue of concern for all midwives, for those working as international midwifery consultants or expatriate project workers, trainers, or managers, it is particularly problematic. The temptation to allow oneself to be seen as an expert in these situations is even greater. In the eyes of the community, women and other midwives, there is the likelihood of being perceived as identifying with the project managers, donors, and politicians rather than with the local midwives and women. The issue applies to all who work in the field, regardless of cultural or educational background, or even of the position and status or experience of the midwife. Read that again. The temptation to allow oneself to be seen as an expert in these situations is even greater. In the eyes of the community, women and other midwives, there is the likelihood of being perceived as identifying with the project managers, donors, and politicians rather than with the local midwives and women. The issue applies to all who work in the field, regardless of cultural or educational background, or even of the position and status or experience of the midwife. Amen. It is particularly problematic when working in countries that do not have recent experience of personal autonomy or personal responsibility. Midwives in countries that have a particular political tradition of being controlled from the center are more familiar at looking towards those in power or to experts to dictate the actual activities of care provided. They are not familiar with democracy or participation in decision making, and may feel slightly afraid and unsure when introduced to such approaches. Sad. It is important for the consultant to avoid falling into the trap of being seen as the person who knows and who will tell them what or how something needs to be done. For the consultant faced with enthusiastic individuals eager for change, tight work schedules, needs that often far outweigh resources and or expectations that he or she will be able to sort out the problems, it is not always easy to hold firm to facilitation skills and participatory approaches to decision making. In these situations, advocacy can easily stray into paternalism or maternalism, and then only the voice of the expert midwife is heard. The midwife's role is always to encourage women to find their own voice, and always to ensure that it is the women's voice that is being heard. The key skills for the consultant midwife are listening, supporting, and participating in the daily lives of the women they work with. The midwife working as a consultant in whatever field or country needs patience, humility, a good sense of humor, and a great deal of self-determination and self-esteem to carry the role effectively. The role of the consultant can be lonely. Therefore, anyone taking it on should also ensure that he or she has a good personal support system from family, friends, or colleagues back home. Page 55, Safe Motherhood Initiative, ... Other strategies include economic support through women's income-generating projects or savings schemes, education of the girl, child, and women, and increasingly gender training for both men and women, ? The latter will help address the inequalities in health, and provision of equal importance is the access to reliable immunization programs. A trained attendant at Delivery and Emergency Obstetric Care and Services, EOC, May 1990, has outlined the need for EOC to be available near to where the birth occurs. Emergency obstetric care to be available near where the birth occurs. Page 56, Safe Motherhood is obtainable from WHO in Geneva. Many of the documents and reports are free, no cost, particularly for developing countries. For further information, write to Maternal and Newborn Health / Safe Motherhood Unit, Family and Reproductive Health, World Health Organization, 1211, Geneva 27, Switzerland. ... The package makes strong recommendation. That was a free newsletter is available, containing articles and up-to-date information from around the world on safe motherhood programs, research events, and resources. This, along with other documents related to safe motherhood, is obtainable from WHO in Geneva. Rewind for the address. Developing the midwifery skills of their health personnel, especially those providing community-based care. The recommendations included strengthening of midwifery skills in all aspects of maternity care provision, Importantly, these skills must include the immediate management of selected obstetric emergencies, such as hemorrhage, prolonged and obstructed labor, puerperal sepsis, and hypertension in pregnancy. They also detail the minimum package for basic maternity care, both in terms of what services should be available and the requisite equipment. 1996 saw the launch of the WHO Midwifery Education Modules for Safe Motherhood, WHO 1996, ... The other 4 modules deal with the 4 major causes of maternal mortality: obstructed labor, preeclampsia and eclampsia, postpartum hemorrhage, and puerperal sepsis. They are complete training packs and include games, puzzles, and quizzes to help both the teacher and the student. They have been thoroughly field tested in more than one country and are available free from WHO Geneva. 1996, WHO held a technical working group on normal delivery. This was a working group of internationally credible obstetricians and midwives who together reviewed the evidence for all the current practices and interventions used throughout the world in caring for women having a normal delivery. They have concluded that there are many practices for which there is now sufficient scientific evidence to demonstrate that they are harmful and should be abandoned. These include delivery in the lithotomy position, liberal use of episiotomy, routine perineal shave, and enemas, and many more. There is also a list of interventions for which scientific evidence dehumanizing. There is also a list of interventions for which scientific evidence is available and supports both the use and promotion of these interventions. These include the provision of continuity of care, making care more humanistic, helping the woman to remain as mobile as possible during labor, and allowing the woman to adopt the position of her choice during delivery. WHO 1996, 6b. This document, along with other safe motherhood documents, is available from WHO Geneva. Other global events significant to safe motherhood. 1990 saw global action towards improving the health and well-being of children and the International Congress. World Summit on the Health of the Child. This summit put the child on the world's agenda. UNICEF 1990. At the UN General Assembly in 1990, the Convention on the Rights of the Child, UN 1990, entered into international law. Both at the World Summit and by signing the Convention on the Rights of the Child, governments agreed that they would take steps to increase the health of children throughout the world. Article 6, which deals with survival and development, lays down the need for effective prenatal care and the right to have the delivery conducted by appropriately trained health personnel. Other articles deal with non-discrimination, effectively outline practices such as gender selection, female feticide, and discriminatory feeding practices based on gender, and the best interest of the child, separation from the family, and family reunification. By 1997, the Convention on the Rights of the Child had been ratified by all members of the UN except for Cook Islands, Oman, Somalia, Switzerland, the United Arab Emirates, and the United States. UNICEF 1997a. Fourth World Conference on Women in Beijing 1995. This included provision for strengthening the health services to women, particularly in and around childbirth. This is of concern to all involved in safe motherhood. It underlies the fact that there is no room for complacency in the attempts to make motherhood safer, if not completely safe. What is completely safe? Therefore, the training of health personnel in effective midwifery skills is an urgent, continuing, and priority need. Safe motherhood, then, is not just about ensuring that women do not die in childbirth. It is about empowering women to take control over their own bodies to enable them to achieve optimum health. This must include being empowered to make effective and informed choices about if and when they will embark upon pregnancy. If they choose to become pregnant, then they should have access to all services, education and support, including community support, needed to achieve a healthy outcome. This includes being assured that the child can reach healthy adult maturity, for without this, the pressures on women to conceive many babies will not reduce, and family planning strategies will be impeded. The strategies required to achieve all of these will vary from country to country. The strategies are as much or more concerned with the sociological perspectives of women's health as they are with the provision of effective health services. As Thompson and Bennett, 1996, outline in their pre-Congress paper, the provision and access to health care has only a small effect on the overall determinants for the health of women. It would appear that by far the most important factors for improving women's health are changes in the cultural practices, eliminating gender inequalities, and improving the environment in which the woman lives, which includes elimination of poverty and improved nutrition. I can't help but think when they say elimination of poverty, where that money will come from. How to eliminate poverty would seem to imply that everyone might be impoverished, become impoverished, or just above a poverty line. This inevitability means that in addition to developing appropriate technical midwifery skills, and who defines the poverty line, midwives must also involve themselves in political action to address these issues, which have a direct effect on improving women's health. Midwives must also involve themselves in political action to address these issues, which have a direct effect on improving women's health. How thin can a midwife be stretched before catching babies doesn't become what she's really good at, and the complications that may arise at birth? The role of the midwife in safe motherhood. ... Whilst women in highly industrialized countries are subject to a different lack of control over their own bodies than women in developing or transitional market economy countries, both are denied their rights. They are denied the right to choose and denied their right to exercise control over their own birth processes. Some Western countries are making progress in this field. New Zealand is perhaps in the forefront of ensuring that women have the right to choose what type of assistance they want during pregnancy and childbirth, and where and when they want it, or shouldn't it also be what type of assistance they may or may not want, if any. The UK is another with its Changing Childbirth Initiative, DH 1993. Other countries are developing similar initiatives and are trying to give choice to women for care in pregnancy and birth. However, in too many countries, the health system, structures, and medicalization militate against effective implementation of safe motherhood programs. For this reason, midwives must become more politically active and learn to relate to, work with, and seek to influence the leaders and major decision makers, both at the local and national level. It is with humility that midwives can boast that throughout the Safe Motherhood Initiative in many countries, they have played and continue to play a pivotal role in helping achieve the goals of SMI, yet more is still required. What is the end? Where does it end? Breastfeeding and Baby-Friendly Hospital Initiative, BFHI, ... This, unfortunately, and despite scientific evidence showing the importance of breastfeeding for maternal, infant, and child health, global Indicators demonstrate that the decline of breastfeeding in the 1950s and the trend towards bottle feeding has continued in the 1990s. SADA, SAADEH, 1993. This is despite the research which supports the promotion of exclusive breastfeeding in the first 4 to 6 months, particularly for the control of diarrheal disease and upper respiratory tract infections. Following a review of the then available scientific evidence, SADA 1993 concludes that the results showed that breastfeeding can save more infant lives and prevent more morbidity than any other intervention strategy. Breastfeeding has to become an intervention strategy because of the people that messed it up in the first place. Hospitals who wish to work towards the award of the status baby-friendly hospital, WHO also provides a similar course for breastfeeding counseling. Going back, the BFHI was launched in 1991 following the joint WHO-UNICEF statement on breastfeeding in 1989, which outlined the 10 steps to successful breastfeeding, WHO-UNICEF 1989. The 10 steps, see Chapter 36, have become the management tool and criteria for awarding BFHI status. UNICEF now provides a training package for hospitals who wish to work towards the award of the status baby-friendly hospital, WHO also provides a similar course for breastfeeding counseling. Both courses have been implemented in a growing number of countries, with some countries incorporating them into their own national breastfeeding programs. Difficulties to be overcome. Despite these global initiatives, the lack of exclusive breastfeeding for 4 to 6 months and the practice of discarding the colostrum remain the two major difficulties to be overcome in many countries. Very often, such practices, influenced by strong cultural superstitions and belief systems, cannot be overcome by simply presenting mothers with scientific evidence. A recent report suggests that the promotion of exclusive breastfeeding is still being hampered by inappropriate advertising and violations of the International Code of Marketing Breast Milk Substitutes, UNICEF 1997b. The aim of the code is to eliminate inappropriate marketing of breast milk substitutes, WHO 1981, despite almost universal agreement that it is unacceptable and immoral to import and promote formula feed to countries where the water supply is not safe. Violations of the code continue. The International Baby Food Action Network, IBFAN, and others seek to promote and protect, as well as to identify violations of the International Code of Marketing of Breast Milk Substitutes, international agendas, midwifery identities. It would appear that the global concerns of midwives and the constraints they face have changed little since Quast and Bentley's 1991 paper was presented at the ICM pre-Congress workshop in 1990. In their paper, they present a view of the constraints and problems facing midwives worldwide, which outlines both the shortage and maldistribution of midwives and the economic and training problems facing midwifery in many countries. Midwives need specific policies and legislation to practice. One of the most common and urgent needs facing midwives in many countries is the need for specific, if not separate, policies and legislation to enable them to practice. What about the exercise of freedom? Where separate policies and practices for midwifery are not identified, midwives can be hampered if they have to practice under nursing protocols and legislation. Where separate policies and practices for midwifery are not identified, midwives can be hampered if they have to practice under nursing protocols and legislation. For example, many of the procedures the midwife requires in order to practice essential life-saving skills as identified in the WHO Mother Baby Package, WHO 1994b, are not always allowed under nursing policies or legislation. Many of the procedures the midwife requires in order to practice essential life-saving skills as identified in the WHO Mother-Baby Package, WHO 1994, are not always allowed under nursing policies or legislation. By far the most common and continuing issue that faces midwives internationally is their right to practice. The manifestations of this issue will vary depending on the country concerned. For many, the domination of the medical profession will be the most difficult barrier to overcome. It is heartening to read, for example, that as far back as 1985, WHO and some obstetricians recognized the pivotal role of the midwife in providing quality maternity care. Wagner, 1994. However, too often the relationship between the two professions remains contentious and leads to the fragmentation of care and services for women and babies. The principle of providing holistic care to mothers and babies as a unit is still more observed in rhetoric than practice in many countries. For many countries, especially in Russia and the whole Eastern Bloc, maternity services for pregnancy and childbirth are still dominated by medical practice, with almost 100% of all deliveries taking place in a hospital environment under medical supervision. Indeed, in some of these countries, midwives are faced with falsifying records to indicate that the birth was conducted by a medical officer when in fact it was a midwife who conducted the delivery. In addition, the unique nature of midwifery practice as separate and distinct from nursing is still not universally accepted. The unique nature of midwifery practice as separate and distinct from nursing is still not universally accepted. In countries such as many in Africa, there are logical and rational reasons for having nurse midwives, and midwifery care can appropriately be a qualification obtained after training as a nurse, especially where the nurse midwife may be the only healthcare person available in a rural setting. Yet even in these situations, there are still issues which must be addressed. The two professions have a distinctive, if overlapping, body of knowledge and practice. They both need valuing for their individual contribution to a nation's health, and legislation and structures must reflect this. The legislation must be sensitive to the particular country situation, yet still allow the midwife to undertake all the skills necessary for saving life. License to practice is an issue of safeguarding the public and therefore a matter for government concern. So government must ensure that the professional standards. Tell him to turn that noise down out there, please. License to practice is an issue of safeguarding the public and therefore a matter for government concern. So government must ensure that the professional standards remain central. Governance must not be confused with political interference or dominance in the determination of professional standards. It is the responsibility of governments to ensure that frameworks exist which will ensure that individual health practitioners have appropriate education and supervision to enable them to fulfill their individual functions. For example, where trained TBAs are considered essential to fulfill a need in the country, their role should be regarded as integral to the rest of the maternity service provision and not seen as something outside the formal services or replacing the need for sufficient numbers of appropriately qualified midwives. It is also important to ensure that where TBAs are used, they are adequately prepared for their role and are properly supervised and encouraged to work closely with qualified midwives. Without this, the TBA will always remain outside the formal health structures and will be vulnerable and may not be valued for her expertise. More importantly, she may feel unable or unwilling to seek appropriate help if and when it is required. Questions such as whether there is a place in modern midwifery for such workers or whether the TBA should be a support worker for the trained midwife have not yet been resolved in many countries. Education of midwives. The education of midwives is yet another matter of debate and concern in many countries for a variety of reasons. As previously stated, in some countries the preparation of midwives may follow on from nursing. There are a number of disadvantages to this, particularly where nursing does not have a sufficiently strong public health basis. The arguments for and against midwifery following nursing will depend on the individual country. However, it is useful to consider one or two of the more common reasons. The midwifery following nursing model can result in midwifery being seen as an adjunct to nursing. The consequence in some countries is that midwifery is afforded very little time with the curriculum, as happens in Japan, where the midwifery component only lasts 6 months. It may also lead to fragmentation of care between an institutionalized intrapartum service and separate community-based prenatal care. Role confusion can occur in some countries where the prenatal services are provided by community health workers or public health workers completely separately from midwives who offer intranatal care. Often these workers have minimal midwifery input into their curriculum, as occurs in the Family Welfare Visitors Program in Bangladesh. M. Leopard, Personal Communication, 1993. LEPPARD. Training must be skills-based. Midwifery is essentially a practical profession, where practice is underpinned by evidence and sound practical application. The skills required by the midwife may vary slightly from country to country depending on the specific needs of the country. These skills may include being able to competently undertake a manual removal of the placenta or give intravenous injections of an oxytocic drug for control of postpartum hemorrhage. However, even without drugs, the midwife may find herself in a situation where her knowledge and skills alone can save the woman's life. Faced with a woman having a severe hemorrhage after delivery, the competent midwife, if trained correctly, should be able to apply aortic pressure. This is where the midwife, using her clasped hand, exerts downward pressure on the abdominal aorta to reduce flow of blood to the uterus. Figure 4.1. Page 61. The correct application of aortic pressure may be the only option available for a midwife to stem the flow of the hemorrhage until medical assistance is available. Training for these and other life-saving skills must focus on achieving competence. Very often in some countries, whilst the theoretical knowledge may be taught well in the initial programs, there is little or no opportunity to practice the skills in the clinical situation. Frequently, the trainers themselves may lack confidence and competence in these skills. Training for these and other life-saving skills must focus on achieving competence. Very often in some countries, whilst the theoretical knowledge may be taught well in the initial programs, there is little or no opportunity to practice the skills in the clinical situation. Frequently, the trainers themselves may lack confidence and competence in these skills. Direct entry programs. With the above in mind, many countries such as the USA and Canada are exploring direct entry into midwifery. Direct entry programs are established in some countries such as France, the UK, and Holland. This, some people feel, would allow more appropriate programs based on a fitness for purpose model. The fitness for purpose approach to curriculum planning, figure 4.2, looks at the required competencies of a midwife for that particular situation or country. From this, a program is then devised which demonstrates how the outcomes and the necessary skills, knowledge, and attitudes to practice competently will be met. These should be pertinent to the country in which the training takes place and conform to the international definition of the midwife, WHO, FIGO, ICM 1992, WHO in the mother-baby package suggests that countries with high maternal and infant mortality rates must look at improving midwifery skills as a matter of urgency. WHO, 1994. Attempts are being made to strengthen the skills of midwives in many countries. However, this is complicated by the fact that identification of who is a midwife is not always easy. However, this is complicated by the fact that identification of who is a midwife is not always easy. In a recent survey across the 10 countries that make up the WHO Southeast Asia region, there are approximately 18 different categories of worker providing maternity services, of which only 7 have midwife in their job title. WHO SEARO, SEARO, 1996. Some, such as the border midwives in Bhutan, BHUTAN, have only 3 months training in midwifery and provide delivery-only care. Would definitely love to visit there. One of the main difficulties facing the preparation of midwives is the dependence upon the country having sufficient appropriately trained midwife teachers. Many countries, including some European countries such as Germany, are without a standardized approved preparation for their midwife teachers. Standardized, my note, versus individual and unique, as every woman, every pregnancy is individual and unique. Not only is every midwife individual and unique, but should training be so standardized as to not be flexible and nuanced as to include individuality and unique. Be unique. It was partly for this reason that the WHO funded the development of the midwifery modules for safe motherhood, WHO 1996A. Also, the omission of research from the curriculum, as has happened in many well-established midwifery programs, Sweden being one, is detrimental to the preparation of critically thinking midwives. Midwives must be able to be both proactive and responsive to the needs of individual mothers and babies. Many countries are now addressing these deficiencies, but some are being hampered by medical, particularly obstetric and pediatric domination. Such medical dominance makes undertaking appropriate midwifery research problematic. Without midwives who are active researchers, not simply research assistants or data gatherers for medical research, but midwives engaged upon midwifery research, it is difficult to build up sufficient evidence-based practice. Therefore, it is essential that some midwives become researchers as well as research users. It is imperative that each country has a mechanism by which some midwives are able to receive adequate preparation as researchers to ensure that country-specific midwifery research is carried out. Such research is not only essential for evidence-based practice, but is needed by governments and other decision makers to allow them to improve their maternity services. Employment and the working environment. Other problems that face many midwives worldwide include issues surrounding employment and the environments in which they work. Changes such as the rise in human immunodeficiency virus, HIV, and increasing migration to city dwellings, bringing with it the demise of family support networks for childbearing women, will require different approaches to the provision of maternity services. Mass urbanization, with the results of overcrowding, increased poverty, and deprivation, often leading to higher crime and violence, has resulted in an increased concern for the safety of midwives at work. Even in some Western countries, midwives fear for their own safety and are reluctant to go out to laboring women at night without some sort of security cover. Question mark, where? This is the very nature of the work to go out at night. Government services become concentrated on urban populations, with rural families being unable to afford private health care. Other issues also face midwives in the rural areas, such as inadequate infrastructure, housing, transport, and education, which can result in midwives with families not wishing to work in these communities. Finally, in many countries, health service funding often fails to take into account remuneration for community practice, payments being based on formal, structured care from hospitals or health centers. In all of these situations, community services and the setting up of independent community practice become difficult and devalued. Even some Western countries, such as the UK, some states in the USA and Canada and Norway, are facing similar problems with independent midwifery. In the more industrialized countries, however, independent practice is proving difficult due to insurance companies not wishing to pay for this type of service for a variety of reasons. Often the reason relates to the close association with the medical profession, who are generally hostile and antagonistic to midwifery-only care. As funding of healthcare becomes increasingly reliant on insurance schemes, as appears to be happening in many countries, this is likely to become an increasing problem. The success of the midwives in the Netherlands and the New Zealand midwives initiatives to have their services recognized as a legitimate option for pregnant women offer hope. However, these successes were as a result of hard-fought battles. In the Netherlands, 2 out of 3 babies are born with midwifery-only care. Smulders and Limburg, 1995. But the medical profession continues to try to gain control by establishing criteria for women who, in their opinion, require hospital care for birth. In New Zealand, the midwives' fight to have the Nurses Amendment Act passed in 1990 was not without fierce opposition. Donnelly, 1995. In each case, although circumstances may be different, the force of medical opposition was enormous, and the midwifery profession had to unite and work in partnership with women to achieve success. In both accounts, the force of the women's support was paramount. This can only be achieved if women are free and able to offer the support, free in that they are not excessively burdened with malnutrition, ill health, and poverty. Unfortunately, in some countries, many women are still being denied such freedom. Increasingly, turbulence, war, and political upheaval are posing new problems for midwifery. The recent stories that have emerged from Rwanda and former Yugoslavia of the attempts to carry out what has become termed ethnic cleansing give graphic testimony to the impact such upheaval causes to women. Violence against women is more than ever on the international agenda, despite the UN Convention on the Elimination of All Forms of Discrimination Against Women, UN 1979, and the Declaration on Violence Against Women, UN 1993. Female genital mutilation is still a concern in many countries, as is the damage inflicted on women as a result of lack of appropriate health care in pregnancy and childbirth. Morbidity, especially pelvic floor problems, incontinence, and vesicovaginal fistulae, and the provision of appropriate and safe reproductive health care for refugees and displaced persons are perhaps the most pressing concerns for research and innovations by midwives at the turn of the millennium. Midwives need to be aware it is not possible to reflect all the issues or the different approaches being made by midwives in different countries in one short chapter. What is possible, though, is to heighten all midwives' awareness that today, more than ever, globalization does have an impact on midwifery. As such, midwives from both a theoretical and practical point of view should be aware and keep abreast of what is happening in other countries. Summary: globalization and the impact of technology require midwives in all countries to be aware of just what is going on in the world. In addition, midwives must become more politically active if they are to bring about safe, in our parenthesis, motherhood in their own and other countries. It is clear that what is required to bring about safe motherhood in most countries is sufficient, well-trained midwives and the resources to provide holistic quality care, including emergency obstetric care. These must be available close enough for the women to gain access to them. This requires action by community leaders, policymakers, and politicians. Therefore, midwives must become active in political debate concerning structures of society, but also be able to identify and influence local leaders and key decision makers in the community. This is more likely to succeed if done through rational, considered discussion and community grassroots action. This is such a question as to what involvement a Christian midwife would have in these issues, as our kingdom is not of this world. Awareness of one's own culture, both personal and professional, will help in adopting appropriate and culturally sensitive models for action, including models of care. Midwives must accept that their own cultural baggage will alter their perspective on best practice and fitness for purpose. Not all cultural things are baggage. Therefore, adopting an advocacy role and participatory approaches is not only good practice, but the only way forward. This will require all midwives to ensure that at all times it is the women they serve who are in the front and making the decisions. Thank you. If midwives are to provide appropriate, effective care anywhere in the world, they must always listen to and respect the women they seek to serve. And that definitely includes preceptors and students. Both, where learning is a two-way street. And if a preceptor doesn't understand that, run and find one who does. Maybe enter the way some of the best midwives and most well-known midwives entered, through self-study. Perhaps also the granny midwives who relied on prayer. The many midwives who have relied on prayer and on God. And that is valid, because God can quicken a midwife to know what to do in an emergency situation. Not to discount knowledge, as much knowledge as the midwife can obtain, of course. Awareness of one's own culture, both personal and professional, will help in adopting appropriate and culturally sensitive models for action, including models of care. Midwives must accept that their own cultural baggage will alter their perspective on best practice and fitness for purpose. Therefore, adopting an advocacy role in participatory approaches is not only good practice, but the only way forward. This will require all midwives to ensure that at all times it is the women they serve who are in the front and making the decisions. If midwives are to provide appropriate, effective care anywhere in the world, they must always listen to and respect the women they seek to serve, or mentor. Page 64, 1. Try to obtain a copy of the ICM Code of Ethics and ask yourself how your practice complies with this code. 2. With a colleague, consider how you as a midwife support each individual woman you care for in her right to participate actively in the decisions about her own care. My notes. She is the decider. Try to find an opportunity to meet with small groups of local women and ask them to tell you about the maternity services they receive and the type of maternity services they would like to receive. If possible, try to include a small group of women from a minority ethnic group. Ask yourself whether they all have similar experiences. Do they all voice the same concerns? What are the striking similarities and differences? 4. If possible, try to find another midwife who has worked or is working in another country and ask her or him to tell you about the experience. 5. You may like to try to find a midwife in another country with whom you can establish regular correspondence as a pen friend. Midwifery journals or midwives organizations can sometimes help to put midwives in touch with each other in different countries. The ICM would have the contact addresses for many national midwifery associations. Going back to page 62, figure 4.2, fitness for purpose curriculum model. Needs of childbearing women I highlighted, and lifelong learners, reflective and reflexive practitioners. The end of Myles chapter 4.